Professor Rosenthal, that is a professor of surgery and well-known worldwide, professor at Cleveland Clinic in Florida, Case Western Reserve University, and a worldwide famous bariatric and minimal invasive surgeon. And he has a lot of experience with virtual imaging and in particular utilization of fluorescence. So because of this logistical issue, we will start with him. So please, Raul, if you want to start your presentation, and then we will have a short discussion after that.
Well, I think when we talk about imaging, I have to say that since my early start in surgery 32 years ago, after laparoscopy and ultrasonic energy, this, I think, it's the most important advance in surgery that will benefit not only our patients, but it's going to benefit also the outcomes of our patients dramatically. So to see or not to see, that's the big question. Fluorescent image guided surgery started with a description by Osamu Shimohara years ago, describing the green fluorescent protein, or the GPT, and that entailed them the Nobel Prize of Chemistry in 2008. So this continued to evolve, and Eric Betzig, Stefan Hell, and William Murner also obtained the Nobel Prize in 2014 in chemistry by the development of fluorescent microscopy. So fluorescent imaging is not new. ICG has been around since I was born in 1959, and it's taken 62 years for us to wake up and understand how important this is. And you can see the number of publications that continue to increase. Equipments, there is no industry, there is no imaging modality that is not equipped nowadays with fluorescent imaging. We can see its use in all disciplines. Here you can see neurosurgery. If you look on the red side, on the left-hand side, how the neurosurgeon is pointing at something that you don't know what it is. Well, if you mark it with fluorescent imaging on the right side, you see very clear the ventricle that you don't want to injure, you don't want to harm, you don't want to open. For head and neck surgery, when it comes to thyroids and parathyroids, this is so important. We know that the parathyroid glands autofluoresce. You can see them by just shining infrared light. We don't know why, but you can see how nicely you can identify an adenoma, and you can also identify when you do a thyroidectomy that you took out the parathyroid gland. So here you can see a study, 3 centers, 210 cases, lobectomies and parathyroidectomies. The parathyroid glands glowed in 98% of cases. So this is another study that we published in the Journal of the American College of Surgeons in 2019, where we were comparing the effectiveness of looking at the thyroids with white light or with near-infrared light. And you can see that with the parathyroid glands could be identified much, much better using near-infrared light than when using white light alone. You could confirm on the specimen that the parathyroid gland was removed. And what you can do with that is reimplant it. And with that, you diminish hypocalcemia to 8.2% comparing to controls when only white light alone was used. That was 16% of hypocalcemia. In thoracic surgery for esophagectomies, we know that what's important is not only how much the organ will shine when you do an angiogram. What you see here on the right-hand side is the gastric tube that we fashion, and you can see that it is not only important the amount of fluorescent dye you got on the tube, but also how quickly it perfuses. So the Japanese are really masters here, and they will tell you that you need to look not only at the image, at the signal, at the emission of light that your eyes receive, but also at the speed, how the graft will fill in. Because when it comes to fluorescent angiography, there is an arterial and a venous phase, and they might overlap and give you the wrong signal. We use it for sentinel lymph node detection. We use it for identifying the thoracic duct, as you can see here so nicely, on the left with white light, on the red with infrared light. So you tell me, which light do you want to use when you're operating on a patient? Here you can see a patient undergoing an esophagectomy, and I'm going to show you in a second. This is with my partner Manny Lomenzo, originally from Sicily. How nice we can see the graph when we are in the chest before we do our anastomosis. In the interest of time, here you can see how we look at the esophageal stump. We can see that there is good perfusion of the esophageal stump. With white light alone, you cannot assess that so nicely. And the same thing with the gastric tube. We can see how the gastric tube has also very good perfusion. Here you can see the gastric tube. So esophagectomy, perfusion, sentinel lymph node, this is revisional bariatric surgery. In esophageal surgery, the leakage rate described in the literature is between the liars that are 5% and the reality surgeons that is between 15 to 20%. In bariatric reoperative surgery, the leakage rate when you reoperate is close to 20%, depending on what kind of operation you do. In my experience, it's about 10 to 11%. And here you can see a patient that we convert an omega loop gastric bypass, an operation that it's been banned in the past in the United States, and we're trying to bring it back. How we can see very nicely the blood flow to the new anastomosis between the gastric pouch and the small bowel. For breast oncology, this is so important. The Veronesi Institute was pioneering sentinel lymph node biopsy for breast cancer. You can see how nice you can see that lymph node shining when you do your sentinel lymph node biopsy. Here the same. On the right-hand side, you see on the left-hand side the team working. On the right-hand side, look how nice. This is using the Elevision device, the Vision Sense, that in my opinion is the best device on the market. And I'm sorry I have a conflict of interest since I'm a consultant, but I say it is the best device because what you see has a number. And if we cannot measure, we cannot get better at. The beauty of this device, it will give you a number so you can record what is the intensity of what you're looking at and make decisions accordingly and compare that to the outcomes. Here you can see again how nice you can see the lymphatics when doing axillary lymph node dissections. Same thing with melanoma. When you do your sentinel lymph node, you will see how nicely you can see the tissues and the lymph node. In a case like this one, injecting ICG near the melanoma. Here you have the Elevision equipment and see the beauty of the colors, how the human eye can immediately identify the duct. I like the white and black mode for perfusion. I like the color mode. See how nice here you can see using the dual mode with white and infrared light at the same time, how the surgeon identifies the lymph node, avoiding injury to other structures. So plastic surgeons, for them, it's, I would say, standard of care. You should not do a flap in 2021 without using ICG. You can see here a meta-analysis published by Chen in the Annals of Plastic Reconstructive Surgery, 243 papers, 26 analyzed flaps and autologous reconstructions were used to evaluate those flaps. And again, it was definitely significant to have the fluorescent imaging device to do your angiogram and see that there is viability of your flap. For cholangiography, well, we have studied we published our trial in the Annals of Surgery, the only prospective randomized controlled trial that tells you that literally when you operate on the biliary tree, if you don't have the near-infrared light on, you will miss that common bile duct so nicely, specifically for the young surgeon. And we know that those bile duct injuries do not occur always when the patient has Hemiritis syndrome, but they occur sometimes in a very simple cholecystectomy. If you use combined infrared and white light, you can see better. And the power of this study, that not only you could see better the junction between the cystic duct and common bile duct and cystic duct and gallbladder, you could see also the common hepatic duct, the right hepatic duct. In red colors is always the infrared light, in blue, the white light alone. the cystic duct common bile duct junction. But the strength of this study was that there was no mortality associated, there were no adverse effects, and more important than that, near-infrared fluorescent cholangiography is incisionless. You don't need to cut. So the Strasberg 1 or Bismuth 1 injury is history if you use fluorescent image-guided surgery. They use it also for tumors. The Japanese and probably Dr. Giulianotti, Professor Giulianotti, who is the master of that, is going to talk about how you can see with fluorescent imaging the type of tumor, well or poorly differentiated. And look at this video, which is telling. The white light alone, the human eye, when you shine the infrared light with ICG, look at those satellite metastases. The human eye would have missed it. The outcomes would have not been the same. Recurrence rates go higher. And this is all being very nicely documented. This is in Japan, looking at angiography. So this is a holographic image. You inject ICG, you shine the near infrared on the liver that goes to a camera that shines it back on your liver surface, and you can better identify that. So we can continue looking at colorectal surgery. This is the Pier trial. Again, colorectal surgeons have clearly shown that there is no statistically reduction in the incidence of leaks. However, depending the authors on the Pier trial, these Wexner and others, as you can see in this trial, have demonstrated that there is a change in the resection margin. We also looked at near-infrared fluorescent cholangiography to identify the ureters. Here you can see the study from Wexner I was mentioning to you before. The control groups in red, you see they have higher incidence of leaks than the near-infrared group on green. So for uterine identification, there are different types of dyes. You can see how nice you can see the ureter. You can inject now the ICG to your stents. Together with Phil Lowe at Purdue, we created a model that we published in Molecular Pharmaceutics, looking how nice you can see that ureter. There are 2 dyes coming up on the market, FDA trials, phase 2, 3. Sooner than later, we'll be able to see the ureters and measure also kidney function based on the emission of the dye. Lymph node mapping, perfusion evaluation. This is also something that it's down the road, and you will see here very nicely in this case how the surgeon can evaluate the perfusion of the toes of the foot. You see them in black. The surgeon will go ahead and do a nice angioplasty, and you see how the toes come back, and you can decide which toe to amputate, which one not to do. This is cutting-edge technology. We developed a company and published in Surgical Endoscopy the visualization of nerves using near ultraviolet light. No dyes are needed, no antibodies required. This has a major impact in outcomes in surgery. You can see the facial nerve and avoid paralysis. You can see the pudendal nerves and avoid impotence when you use your robot. And nerve autofluorescence, as you can see in our publications, is down the road. We use it, we published our first 17 cases most recently in surgical endoscopy. Head and neck, you can see very nice the facial nerve and its branches. And just to finalize here, you can see very nice a surgeon working on the parotid gland, shining the near infrared, the near ultraviolet light without any dye, without ICG. It's autofluorescence. So again, here you can see it in the head and neck. And in the interest of time, I'm going to move forward. Here you can see also in the brachial plexus in a child how you can very nicely identify tumors. In the dura madre, when you operate on the spine, you see on the left-hand side, all with blood. On the right-hand side, you can identify the dura madre. Francis Collins said that the physician geneticist noted for his landmark and discoveries that the future of technology when it comes to surgery is in perfecting visualization. And I agree with that. We're working and trying to identify with antibodies, tumor cells, measure intensity, doing angiography. This is Phil Lowe sending me this video. You can see with duplex angiogram, duplex of the radial artery, the red dots are tumor cells with chemotherapy and antibody tagged with a dye. So now the oncologist can, in the office, put an ultrasound probe on the radial artery and measure how many of those tumor cells are attached to chemotherapy and see if the treatment is effective or not. We created a society 10 years ago. Fernando Deep, currently the president, Kokuro, Bouvet, Ishizawa, past presidents. We have webinars. We have a phenomenal website. And again, just to finalize, fluorescent image-guided surgery is not evolution, it is a revolution. And thank you very much for your attention.
Thank you, Raul, for this really comprehensive and nice review and of all the indication. Just a very quick question. I know that you have to leave for...
No, I'm not in a rush. I'm good.
Okay. So the question is, there is no doubt that the future visualization in surgery will rely on different modalities. The possibility of seeing what is invisible with normal light. And because the majority of surgical mistakes are done with misinterpretation of the anatomy. That's so your question, do you think that more future will be connected with new generation of colors or colorants or better software to overcome some of the limitation, like the depth of tissue that is covering a structure? And what's your opinion?
Yeah, it's a great question. It's a combination of all of the above. We're going to be using different wavelengths, the whites, the near infrareds, the near ultraviolets. We're going to use different dyes, and we're going to use software. All combined are going to create a rainbow. I think that in the next 5 years, not 10, 5 years, you're going to put a scope into the belly of or into a chest, and instead of seeing one color, you're going to see multiple colors. The vessels are going to shine in red, the nerves in yellow, the lymphatics in blue, the tissue in white or in red. I think the software is going to give us also the ability to differentiate the one from the other. I think that's the direction we are going.
Thank you so much. And then I would like to ask Professor Leo Chen, that is a professor of research in surgery here at University of Illinois, and also the director of the SITL lab. Is an expert of fluorescent imaging. Please, Leo, we would like to go back a little bit, discussing about the basic foundation of this technique.
Thank you, Dr. Giulianotti. It's let me share my screen. Okay.
Yeah.
All right. Yes. Hello, everyone. So it's a great honor to be here. Thank you for the opportunity. I'm not a surgeon. I'm a research faculty here at UIC. So the presentation is really based on from a researcher point of view. The fluorescent imaging, I mean, the title is very broad. So I like to use 2 slides to really narrow down the themes that we're going to talk about in these slides here. So the first one is what I'm going to talk about is really related to the robotic surgery platforms. Currently there is only 1.5, I would say, platforms there. And then of course for fluorescence, we talk about mainly focus on the firefly fluorescent camera with the ICG. So, and the second one is we really talk about is near eye fluorescence, because the firefly camera is only teamed with the ICG fluorescent within the near IR. You heard from previous talk, there's also other fluorescence, although ultraviolet light excitation, you can also see a nice, beautiful fluorescent. But I focus on my talk really on the ICG near the near IR. Okay. All right. With that one here, I'm just going to start back to very, very basic. I hope we're not boring you, and I'm sure some of those already know. First, a little bit history, right? So the fluorescence was first observed by Herschel back in 170 years ago, right? So a glass a vessel of the quinine solutions in front of a church vessel, a church window, on a sunny light. If we put a a glass of wine there, you will see a beautiful, beautiful blue light coming out from the solution, right? And then the Stokes actually termed this phenomenon as a fluorescence back in 1853. If you look at this setup here, I want to make the maybe mention briefly about the hardware needed for the fluorescence, right? So you got on the right side, I imagine there's 3 types of cameras on the XI, on the SI, and as well as the SP. And I put the SP here. The SP really don't have fluorescence yet, but I just want, so you can see here, instead of sunlight, and then we replace it by laser light, and then of course the laser light come in here, and then you get the sample there. Now the camera position is interesting, right? In the SI, the camera actually really on the distal side, so it's a standalone camera. But then on the XI, the camera actually move on the tip, so there is really a chip here. So what the end up is in the SI, the optical passing all the way to the entire shaft of the camera, but in the SI is the electron signal go to this part here, right? This certainly have an advantage that this will enable a flexible camera, right? So as indicated in the SP now, you the entire camera, the stem of cameras actually can be flexible, right? So that's the real advantage. But all in all, you can see there, I mean, the very basic principle is, it's still the same thing there, right? So this is something that is, again, it's just very slide there. In order for a molecule to help the fluorescence, the electron has to be excited states, and then of course it's go to a high level, and then eventually go to the lowest level excited states, and then from there the electron actually give out their energy as the form of light. So all I want you to remember that the lowest excited state actually is the key state have to relate to fluorescence. Just keep that in mind. I will mention this one again in the later slide there. Again, I don't want to use any formula here, but just as you can see there, some factors affect the fluorescence intensity. This is very straightforward. You need a very strong light, right? And then of course it's not all molecules have a fluorescence. So some molecules, the fluorescent quantum yield, the quantum yield is very important, right? So the quantum yield means if you give them 100 photon there, how many photons come back as a fluorescent, right? And so on and so forth there. So there are 2 types of fluorescence, as you can see from the previous talk there. So one is actually based on the tissue intrinsic optical fluorescence, right? So there's a lot of autofluorescence come from tissue. You actually can grab that opportunity to observe things like you can see the parasitoid or some tumor mass, right? In this case, in other strategies, one that normally your target tissue is not different from the normal tissue. There's not enough contrast there, so that's why you have to use a contrast agent to light up the tissue there, so that you can see. In this case, you do need to inject the contrast agent to this, right? So that goes to the ICG, right? So the ICG actually is a memory of signing dye molecules. The reason for the scientists to develop this one to go back to near the 55, where the Kodak, I don't know how many people still remember the color film business there. That's of course nowadays nobody uses film anymore, but at that time, color film is the major business of Kodak, and then that's what's used actually was synthesized by the Kodak and for the application of the film industry, and then of course it's used by FDA, and of course it's also approved by FDA in 2011 for combining with the firefly. So I want to emphasize one people know a lot with photophysics about the ICG, but the one property I should emphasize, I feel that is not well. Okay, so this slide just talk about that there are 3 types of FDA approved, and you can see here that the quantum yield of the molecule is very different, right? The first thing is very bright. 0.97 means you give them 100 photon there, 97 photon come back as fluorescence, very high yield. But for ICG, it's very low yield. You give them 100 there, they only give you a 12. This is actually in water, actually in organic solvent. It's in water, that's even less, right? So maybe 0.07, something like that. So it's a low yield, but still people like to use it because the emission window is very special, because there are emission windows actually right into the region there were not too many autofluorescence from tissue to affect you. You can see this is the blood, the absorption there. So in this region here, in region there, that's the lowest point. So that's why the ICG was commonly used, right? As I mentioned, that the ICG, there is one property I think ICG people didn't talk about a lot, but I think it's very important. I should point out, because think about it, ICG is a family of cyan dye. When people talk about cyan dye, there is one phenomenon called aggregation. You have to mention that. Cyan dye, this is one example of cyan dye. Without changing the color, without changing the chemical structure of the dye, you can just change the molecule, the absorption, the colors by just how they pack to each other. So in terms of the same thing in ICG. So ICG actually can form a different type of aggregate in the water solution, right? So in this case, if they are parallel packed to each other, then what you observe here actually is blue shift absorptions. And then if they packed like head to nail, and then you have observed in the long shift. So in ICG really in water have different form, and then of course give different absorptions. So normally we only use this part normal monomer, but we didn't use this part quite often, right? If ICG is an aggregate, and the aggregate form, the sum of aggregates, for example, the J aggregate is not fluorescent, and then actually it's not as a very good dye molecule to be in vivo application. But because ICG has not, I should go back to this one here. Because of in blood, the ICG can interaction with albumin protein there. Then actually it's actually isolated inside the hydrophobic pocket there. So that's why in ICG in blood there, it always informs a monomers. If that's the case, then the ICG is, I go back to here, is that the ICG always in the monomer format, which have the best fluorescence. So in this case now you can see that for ICG, if you keep adding the ICG to the water solution there, you will see the increase of fluorescence initially, but eventually if you keep adding more ICG there, then fluorescence is gone. And then of course, if you have a very concentrated ICG there, they basically don't have any fluorescence because they form an aggregate and the aggregate don't have any fluorescence. So I think this is important because if you think about you're going to use this one in vivo here, especially you are in a topical injection of ICG there. Now the ICG not interaction with the albumin before, then you should realize that yes, there's a concentrated play a major effect here. The one thing I want to mention about is that an ICG application there, you basically have the first, maybe the very obvious experiment, the application of ICG is to use ICG to observe the autonomy, right? So this is based on ICG circulation, excretion, and retention. And the circulation means ICG can be used to visualize vessel structure, right? Excretion means it's through liver, through bile, they use it for visualize the body structure there. But for retention, I just want to mention some of the research effort around that area. So ICG is frequently used for tumor mass imaging, right? So this is actually a case from Dr. Giulianotti. You can see that he actually injected ICG during the surgery, during the intraoperatively. So you can see it's a very nice negative contrast. In other words, the tumor mass is showing dark mass compared to regular other tissue there, right? But other surgeons also use ICG to introduce ICG preoperatively in 24 hours, 48 hours. So during the surgery, you do see the ICG tumor fluorescence is bright ICG, bright contrast is a very enhanced ICG fluorescence there. But the further study, if you do a lot of pathology study, this is another study from the Japanese group there. If they do the pathology study, they realize that actually the fluorescence only come out from the outer layer of the tumor mass. The internal layer is just like the intraoperative ICG. Actually, the middle part is dark. So they also propose the mechanism that the lipid transport protein provide important roles here. But we think about maybe a different mechanism, because if you look at these videos carefully now, right? So you can see actually at the beginning of the tumor mass actually is bright. You can see here, look at this one here. The tumor mass actually at the beginning actually is also very bright, right? It's also it's about a few seconds, sometime later, you see that the tumor mass become darker now. And then eventually go to that. You look at now, the right become darker now, right? You see the tumor mass, right? It's darker now and then get darker now. and then it further goes dark, right? So really, what you observe here, actually, really, you observe this one here. Actually, tumor mass goes through bright and go to dark and eventually go to dark, right? So we believe this kind of observation is related to the stroma structure of the tumor, which actually the stroma actually is a very rich structure of a vessel structure, leaked vessel there. This is already well established, right? So they also have the enhanced the efflux activity there. This cassette transport cassette protein there. Actually, this is the main reason why tumor mass actually is resist drug therapy, right? Because they actually can pump the drug. Because they have this high abundance of ATP molecule available, they actually can pump the drugs outside the tumor mass. The tumor actually is the stroma layer cells there. So we believe the same thing we observe here. Actually, is the IC module that was pumped out by the APCH cassette. That's why you see at the beginning, but then they all clean up. And the same thing happens if you do it into preoperatively. What you happen here is this is actually the case intraoperative, right? So what you have here is in the normal tissue is bright. In stroma area, of course, it's also bright, right? But in tumor, it's dark. So what you overall contrast here, you have the dark things is the only contrast you see. That's why if you can see it, you see the dark. But if you inject it 24 hours ahead of time, what you have here, your normal tissue also become dark now because the IC in their tissue is all nothing there, right? So what you have there actually is just the stroma layer there, which because they have the leaked vessel, they have the actual albumin there. That's why ICT stay there. So what you observe, the contrast pattern is the black, right? Dark, bright, dark. So that's why, because you observe 3D structure there, that's why you see a bright mass there. So that's what we believe, that's the mechanism. And the current study there that we actually going to prove this mechanism. Okay. I don't know how much time I have here. So the other things we want to talk about is the quantitative measurement of the fluorescence. I'll go to very brief. I think the previous talk is also talk about it, right? And then because if you look at the fluorescence currently, you just see how fast the fluorescence come out and how bright the fluorescence come out. The problem with this approach that I will stop right here is that when you move. Okay, I hope that you see you move back from here to here. Yeah, so this one here, I don't know if you can see here. Yeah. It's the same bright there. If you move to different place there, it shows different color, different intensity, because it depends on how far your tissue is away from the camera. That's also change your intensity there. So pure intensity is really not a good thing to do, right? There's a lot of artifact there. So that's why I think a Japanese group, as well as scientists from ICARD, they also promote this mechanism. Instead of using intensity, they actually using the slope of intensity increase as a model, right? As a way to characterize. So I think that's actually can affect a lot of prevent a lot of artifact. But the problem with this effect, it cannot be used immediately. You have to analyze the video to present it as well. So it takes time. But how do you use this in vivo in real time? So the way we want to do it actually use a technology called diffusion correlation spectroscopy, which is actually have been heavily used in brain surgery. And in this case now, what you have here is a shine laser light, but you detect in the distance away from your laser light there. And then you can see because of the blood perfusion there, and then there is the autocorrelation curve will be changed because so that you can see there, you can see here if you have a slow perfusion there, then you autocorrelation in this region there, but you have a faster perfusion, then you curve on this one here. You actually, based on this one here, we actually develop a system in the SITL lab, and you can see there, if I test the system, just use my palm as a cuff on my whole, and once if you just the normal one here before cuff here, the perfusion index of 0.5. But once you cuff the cuff the calculation there, you blood circulation there, then you actually pump the perfusion that drop to 1.1. But once you release the cuff there, the release that moment there, then you can see a surge increase of perfusion there. So that's 0.45. And then we actually plan to use this similar content. So there's an ongoing research effort that we want to monitor actually the nipple blood effusions during the nipple sparing mastectomy. In this case now, we can actually monitor the real-time blood effusions in the nipple there during the surgery. So this is actually very preliminary data. So you can see in the cadaver lab, on cadaver tissue there, what you see here is, is a very, very, almost no perfusion. Of course, I should say no perfusion at all, right? And then of course, as a control there, live tissue there, then you can see a normal perfusion. You can see a big space here. You can see, you can use this for observe the perfusion in real time, right? I don't want to go to this too much detail. I think I will use some time. The one thing I just want to which one thing that people using fluorescent tracers here. So I should go briefly. So there are 4 ways to go this fluorescence to imaging a target tissue, right? The first one is using just using intrinsic fluorescent property, right? As you mentioned, that Cristoforo previous talk that parasite, you can just use the autofluorescent, right? But not all the target tissue have that autofluorescent. So what people using is using a fluorescent tracer. So where the ICG can link to an antibody. The reason I use the tracer here because this type of probe, this type of tracer, that the fluorescent property is not changed, right? So it's all the same there, and then you just based on the target to the antibody binds the target, then you're in there, right? But there is also another type of what we call probe. What's a probe different from tracer is that once the bind the target, the fluorescent property changed. For example, with the new probe we developed in the lab, that we take the advantage that we know that the ICG form H aggregate. The H aggregate actually is non-fluorescent, right? We put my ICG together, and then of course we're using a linker that is specific to cancer metabolism. So in that case, we broke up this the linker there. Now the ICG has a monomer now. So the monomer actually have a fluorescence, but the aggregate, the H aggregate actually don't have fluorescence. In this way, we really have a turn on fluorescent probe, where in tumor mass there, you actually can see that so for example, here you inject it here, there is nothing there, right? But 24 hours there, then the tumor mass actually just form very bright color there. But doing that one here, we actually, for doing a further study, we figured out that this actually injected at a t=0, but this actually t=2 minutes there. You can see here, you still cannot see all the other fluorescent because the fluorescence is dark, but it's only fluorescent in the tumor area there. But eventually it goes to us. So we also injecting other area there, which is normal tissue there. You can see the normal tissue actually starting also to show up. And of course the tumor also show up, but then the normal tissue show up later, but also disappear early. You can see after 20 hours, the normal tissue also gone, but the tumor area still stay there. So this actually advantage that this kind of probe not only can be used in intraoperatively, but actually also can be used preoperatively. So I think that's also solved that problem itself. So we believe this can also be used, very useful for the cancerous lymph nodes, because if you want to use the intraoperatively, there's lots of background there. Then you got to have some the probe that is different from your background, right? So that's why we think that's important in this application there. So I will skip these things here. The list of few things that we think in the future will be used. Some of the also touched by the previous presentation there. One thing they talk about is, I'm also happy to see the people starting looking at the longer fluorescent ICG, right? In this case, really short wavelengths. Now we talk about 1300 nanometers of light there, and of course, very nicely. And then the last thing I want to mention about it is that, some people also use the fluorescent lifetime, which is very sensitive to the environment. And then in this case, you can combine with the AI and the other modalities, then we can do that one. Okay. So with that, I just finished my talk. We have a new lab in the lab there, and it's a beautiful facilities. And then we certainly welcome to collaboration to this side, to the member of the society. So thank you. I hope I not ran too long over time. Thank you.
Thank you, Leo, for this nice review. It's such a complex topic. I would like to ask very briefly to explain a little bit better the autofluorescence of tissues, because this is a very interesting topic. So do you think that we need different kind of lasers or different kind of energies to activate a kind of autofluorescence of different tissues?
Certainly. I think, to be honest, people still don't quite understand what's the nature of the autofluorescence of a parasite. So it's just, I mean, the first time I heard this, wait a minute, it doesn't make sense, right? I mean, so if you look at all the chromophore in the tissue there, there's just not enough. There's no absorption, anything's observed there. So you're absolutely right. But I think, the previous presenter also talked about people using the UV light to shine on the tissue there. And then, of course, you see the fluorescence maybe in the blue region there. That one can also, unless they have a very, very high concentration of the fluorophore there, that kind of imaging can be easily blended in within the normal tissue there. So it really depends on how, what's the tissue specs there. But I think the trend is really people try to excite the observed fluorescence in the longer and longer wavelengths, right, for observation. So now it's near IR, but now lots of people, current research trend is actually see if we can move to short wavelength IR, because that's more transparent for the normal tissue. But then, a better signal to noise ratio for the target tissue. I hope I answered the question.
Okay, thank you. Let's move on. Then I think it's my my topic is to review the clinical.
Well, I think I like to introduce it. I mean, come on, I like to make an introduction. Let me just give 1 minute, less than 1 minute here. So it's my pleasure to introduce our next speaker. So I think for this audience here, I don't need to go detailed introduction there. Dr. Giulianotti is a pioneer and a true visionary in the field of robotic surgery, and he actually started robotic surgery more than 20 years ago, with of course thousands of cases already performed. He has a long list of world first complex procedure there. I mean, so given the time, without mention all the long list of enormous award and also 300-ish publication there, I just want to point out that the lab we have, the ISIT lab, Dr. Giulianotti is the concept designer of the lab, and I'm happy to inform that the lab has just won the 2021 Future Forward Medical Health Design. So with that, Dr. Giulianotti, it's all yours.
Thank you. Too kind of you. Let me try to explain in few words what I think are the best clinical application of the firefly. That's is the daily practical fluorescence that we are using in robotic surgery with the Da Vinci. And I think there are a lot of advantages. First of all, the technique is very versatile. So you can, in any time during live surgery, you can swap back and forth from normal light vision into the infrared modalities. So it's something that is very easy to use and doesn't require, as Professor Rosenthal mentioned, it doesn't require any invasive technique to inject contrast, and it's very cheap because it's very cheap. I think the molecule it's probably a few dollars cost. It's safe. We have done thousands of cases so far, including biliary and vascular applications, and never we had a side effect or an allergic reaction. Can be repeated multiple times, so you have a therapeutic threshold that is very, very wide. And you can avoid radiation in multiple situations instead of using a cholangiogram, for example. and so it's not interfering much with your procedure. Which are the negative aspect that we should try to improve? I think there is a low tissue penetration, and if a structure is covered with some fat tissue or connective tissue, or there are fibrosis, inflammation, obesity, sometimes the visualization becomes difficult or impossible. And then probably this is one of the, and another important drawback that mainly for biliary, that you have a very intense parenchymal uptake of the colorant. And this is disturbing because you have such a brilliant images with the fluorescence that is interfering with the specific bile duct visualization. But if you're comparing the technique with other modalities of intraoperative images or information, you see that fluorescence is fast, is not interfering with the procedure. So as very, very positive aspect. Let's review some of the application. I think Professor Rosenthal already explained some of them. I will try to speed up and my presentation to avoid repetition. But basically, we can use clinically the fluorescence for biliary imaging, taking advantage of the blood flow with timely injection of colorant to visualize vascular pattern or identification of tissue properties of vascular anatomy, perfusion of the target organ. In transplant surgery, we are using more and more to visualize the perfusion of the transplanted organ. And also already mentioned, there is a big future for lymphnodal mapping and selective lymphnodal detection, and probably one day specific metastatic lymph nodes, they would be detected, nerve identification and spontaneous fluorescence. Let's review some of the images. I think we have experienced now thousands of cases, and you might see that the intraoperative aspect is in majority of cases is able to tell you the anatomy of the common bile duct, the confluence of the cystic duct with the common bile duct, and this is increasing the safety of the procedure, and you don't need to do any invasive technique to inject through the bile duct some contrast. And I reminded that the simple fact that you are opening a structure to inject, if you are misjudging the cystic duct, you might have an injury of the common bile duct. We already published in hundreds of cases, and at least as Professor Rosenthal mentioned, for junior surgeon residents, it makes the procedure safer because there is a better ability of recognizing the critical structure, the critical anatomy. Some images, even during major hepatectomy, you see identification of biliary structure. In this case, I think we have a trifurcation of the extrahepatic bile duct, and with a beautiful understanding of the anatomy during the hepatectomy. Here, identification of aberrant cystic duct. There is some kind of complication that might happen, biliary leaks that are connected with anomalies, and the detection of some of these anomalies, like for example, this duct during the cholecystectomy may allow a more precise control of the structure. Let's, in order to save some time. You see, there is an aberrant small biliary duct that is connecting the cystic duct with the right system. And with normal vision, this duct would have been missed and easily divided. And this could have been the reason of potentially bile leaks. You see, in normal light, you barely understand that there is this anomaly. It's connecting the cystic duct with the right hepatic duct. And another example of variation, since we are using the fluorescence, we are detecting more and more of this little anomaly. Look at this, it's another small duct that is going toward the caudate and stay on the right side of the common bile duct, and after clipping and dividing the cystic artery, would have been easy to injure this duct. So you understand how precise and powerful could be a good utilization of this visualization technology to improve the safety of the cholecystectomy. But there are other difficult cases in biliary surgery, like this was a horful cholecystitis, and we decided to do a partial cholecystectomy. And it was unclear if the cystic duct was obliterated for the inflammation. And so I think we were able to detect the bile leak in the situation from the neck of the gallbladder, see here, and that was, we were able to suture that partial cholecystectomy in order to avoid, even in case like this, where you have a wet surgical field, you still, with the proper technique, with the irrigation of saline and cleaning, you can detect small leaks of, I will speed up. Hepatic lesions, we already mentioned that there are a positive and negative technique for visualizing, and I think mainly considering the importance of the margins, if you would be able in perfecting this technique of visualizing the pseudo capsule of many tumors, being able to respect better margins. I think I see a really an important future in this kind of visualization to improve the margins. Leo already showed this video, but other lesions are interesting. For example, hemangiomas, and this is an interesting case where we changed our plan. Instead of enucleation of the angioma, we did a more formal lateral sectionectomy because there was angiomatous tissue diffuse also in the nearby parenchymal tissue of the liver. There are specific images of other lesions like FNH, focal nodular hyperplasia, that they have a specific perfusion. And I'm envisioning that in few years, with artificial intelligence, we would be able to make a kind of digital pathology simply with the computer analyzing and recording the way the colorant and the fluorescence is appearing and disappearing inside a lesion. making a precise pattern of a perfusion that is reflecting the architecture of that specific tissue. In order to save time, let's move forward. I think the perception of the relationship with the important anatomical landmarks is important in many procedures. The relations between bile ducts and vessels, and the injection of colorant into the segments might allow some precise detection of segments of the liver, and that could be even a positive coloration of the segment if you're injecting the colorant to the specific pedicle, or negative if you're clamping the pedicle and having a systemic injection, and this is improving the anatomical execution of segments. Detection of small lesion. This is an example of a small neuroendocrine tumor that we were unable to detect with the ultrasound. But this hypervascular tumor was easily detected, just attached to the capsule, and we did in this case a selective enucleation of the tumor. So there are many other examples of application in, for example, a neuroendocrine tumor during formal resection of the pancreas, because they are hypervascular, and it's a better identification of the edges for resection of the uncinate. In other kind of surgery like endocrine, we know that lesions in the adrenal, they can be hypervascular or hypovascular. It depends on the structure, but anyway, the technique, it's helpful in identification of tumor, and in some cases doing a parenchyma sparing technique. I have example of cases where we have to do bilateral adrenalectomy, and in order to avoid a hypoadrenal function in this patient, we were able to spare some tissue, and that was doable with the fluorescence. I'm going faster because I think the lesion, the presentation will be too long. For renal surgery, urologists are using for better limited resection of segmental resection, wedge resection of the kidney to avoid removing too much normal functional tissue. And for colorectal, as already mentioned, we don't know yet if a precise evaluation of the perfusion, it's allowing a better functional results, less leak, but definitely the perfusion is an important parameter for microischemia. And sometimes the colon, we know well that it takes time to have a real demarcation in color, and you might have a false perception of the perfusion. There are areas of improvement, probably having a computer analysis of the timing of velocity, as Professor Chen explained. We should be able to have a better quantitative evaluation of the perfusion, able to tell us when there is a critical threshold of perfusion. But let's say even in our daily surgery, already the infrared ICG firefly has become a part of our daily assessment of the perfusion. So there are other examples, a small bowel, the same, as you see, there are marginal, sometimes venous congestion, but it can create the same kind of artifact, but it's always better to decide for the anastomosis. You see this in case there is some congestion, but the inflow with the artery was normal. So for gastric conduit, you see the pulsatile perfusion of the gastric conduit for esophageal replacement. It's an important evaluation. You see there is a marginal area here at the tip of the gastric conduit that it doesn't look, but in normal light, you don't perceive that kind of defect in the perfusion. So we are using routinely for esophagectomy, and in other indications, for example, spleen preserving pancreatectomy. At the end of the procedure, always we are checking the patency of the vessels. You know, the manipulation sometimes the splenic vein might develop thrombosis, and so we are always checking that the integrity of the blood flow after the spleen preservation pancreatectomy. Other example, here there is a repair of aneurysm of the renal artery, and so here after the resection of the aneurysm and the reconstruction, we are evaluating the perfect reperfusion of the kidney. Here you see a bypass and from the renal, the proximal stump of the renal artery, and we can move forward a little faster. And after the reconstruction of the bypass, this saphenous bypass, or we are able to check with the fluorescence that there is a perfect inflow to the inside to kidney. We have done many of these cases, and we have been able always to make a precise assessment of the reperfusion. In the robotic kidney transplant, it's another important assessment. You see the reperfusion of the kidney and the patency of, and here I think what we really need a better quantitative evaluation of. Now we are trusting on the images that are pretty good, but a quantitative evaluation of the perfusion probably would add some better information. This is another example. This is innovative operation, is an auto transplant of the spleen, and at the end, after removing the spleen has been repaired on a bench. The lesion has been removed from the center of the spleen, and the spleen after the reconstruction has been replaced inside inside the abdominal cavity, and the reconstruction has been completed with the robot. And then at the end, of course, we need to be sure that the small as there is a perfect reconstruction of the perfusion. See, this is a small spleen that has been, we have a pulsatile flow, but also the fluorescence is immediately delineating the arterial branches, and with a perfect reperfusion. So in lymphodal mapping, there are many different techniques, but we are using this for gastric cancer, and it's also in, there are many extensive experience, mainly in Korea, in other Asian countries, Japan, where the fluorescence injected even 24 hours before the operation, it might increase the selectiveness of the lymphadenectomy and the completeness of the lymphadenectomy during the robotic gastrectomy. This is one of our cases. So there are different techniques. I cannot spend much time on this. Thoracic identification for thoracic duct identification during esophagectomy, I think is another very interesting, because one of the lesion of complication is the lesion of the thoracic duct during the dissection in the chest. And if you're injecting the colorant in the groin 1 hour before the operation, you may have a nice identification of the thoracic duct, and this might avoid this bad complication during the esophagectomy. Nerve, it's a very hot topic. We don't know exactly which is the mechanism, probably the vascularity of the perineural tissue. You might have some direct images or indirect images that might increase the perception of the anatomy of the nerves. But I think a lot of improvement is an area that we need definitely an improvement in visualization, and this improvement might impact greatly the functional results of many kinds of surgery, hypogastric nerves during low rectal resection, and during prostatectomies, and during thyroid surgery, thymectomies for the phrenic nerves. So I'm very late. I don't spend time for the autofluorescence. That is a very interesting topic, and that might improve the perfection of some operation like a thyroidectomy, avoiding the risk of hypoparathyroidism. So I would like, with this overall summary of our experience in clinical application of the fluorescence, that in majority of cases, the fluorescence is such a versatile technique during surgery, might increase the patient safety, and there are no increase in OR times, doesn't require a different organization of the OR, there is no exposure, and probably in having better software of evaluating, for example, subtraction images of the background of the liver for biliary identification, as an example, and or having selective colorants with different kind of laser lights. But definitely, I agree with Professor Rosenthal that the future of minimal invasive surgery, robotic surgery, and I would say surgery in general is connected with this new generation of visualizing technique. And I will conclude the presentation here. And if there are no specific questions, I would like to introduce Anoop Kowshik, that is a senior manager in charge of imaging and imaging development at Intuitive. So I would like him to describe what Intuitive is planning to do for improving the quality of the images that we think are fundamental for the future of surgery.
All right. Yes. Thank you for the opportunity again to present here at CRSA, and thanks to the other speakers as well. It's always great to hear from clinicians and technologists that are using our technology that we develop. I'll go today and talk about the future of Firefly. Before we get into that, I want to set the stage and give some context as to how where Firefly is today, as that's very relevant to where we're going into the future. So we've been, Intuitive has had over 25 years of experience in the robotic industry space. And over those years, we've released a number of updates to our visualization system. And I wanted to just quickly take the audience through these. So with our second generation system in 2006, we introduced the concept of 3D visualization into surgery. So using 3D endoscopes and a 3D stereo viewer. And that's going to be important as we talk about the future, because that may enable us to do interesting ways of interpreting fluorescence and displaying that information. In 2009, we released our DaVinci SI system, the third generation system. And soon after that, we released an upgrade that allowed Firefly fluorescence imaging to be available on that system. And the uptake was tremendous, and we really learned a lot. A lot of surgeons were using it for multiple applications, and so much so that when we released our fourth generation system in 2014, we decided to make that a standard feature on the system. So all of our multi-port systems going forward since 2014 have Firefly as a default configuration on the system. But we didn't stop there. Just a few years ago, we released our latest generation endoscope for our multi-port systems called Endoscope Plus. And with that came sensitive Firefly mode. And what that does is essentially changes the properties of the Firefly system so that it can detect more or less strong signals of fluorescence, more faint signals of fluorescence. And we'll talk about why that's important in a little bit. So where we are today, the DaVinci Vision system, the kind of the hallmark feature of our system that we're known for is 3D. And you can see our endoscope image on the right here has two eyes, two sensors that are picking up the light. It's a chip-on-tip endoscope. And with that, as I said, they all come with Firefly fluorescence imaging and the necessary light systems, as well as sensors to display fluorescence. And then also important is the surgeon console, where the surgeon will sit and perform surgery. That has a stereo viewer, as I said, to view the 3D information. But it also provides an immersive view. You can think of a VR headset that's attached to the surgeon console. And again, that will be important as we talk through some of the future capabilities that we are exploring. So if you look at the two modes that we provide today, one is standard Firefly mode, which is essentially providing a fluorescence image in conjunction with a black and white image of non-fluorescent tissue. Now, the goal of standard Firefly is to maximize the contrast of fluorescence while preserving visualization of non-fluorescent tissues. So we've seen tremendous adoption of Firefly, standard Firefly, in procedures like cholecystectomy, colon and rectal resections. And our data indicates that a majority of our cases, similar to what Dr. Giulianotti described, are being done with Firefly. And that's fantastic. We really like to see that. It really speaks to the value that surgeons are seeing in fluorescence imaging. Our sensitive Firefly mode, which was released just a few years ago, is our latest mode that was developed really to support exploration of new clinical applications of fluorescence. In some applications, we know detecting fainter levels of fluorescence is required. And so we achieve that by emitting only near infrared light. And that allows us to maximize fluorescence contrast and sensitivity by boosting the signal to noise ratio of the fluorescence. And while we developed this technology and this feature really for future applications and of fluorescence, what we're seeing from surgeons that that they're using it in ICG-based applications like cholecystectomy, where biliary ducts that were not necessarily seen before are now visible. I've heard anecdotally the duct of Luschka, for example, has been visualized. It's unclear at this point if it's clinically significant or relevant to worry about these microducts, but it's worth noting that surgeons are finding utility in features like this today. So while we're pleased with the adoption of Firefly and its ability to positively impact outcomes, we believe we're still very much at the infancy of the technology. When we think about the future, we like to think about fluorescence applications in two main paradigms that I'll describe here. The first one is what I call binary applications. So this is where surgeons just want to know if the anatomy of interest is fluorescing. Is it glowing or not? And this is often for structures that are hard to find or perhaps structures that they want to avoid. So if you look at applications today where that may happen, that's like many of the panelists have already talked about, aberrant biliary duct identification and vessel identification. But also there are opportunities in sentinel lymph node, ureter, nerve, and cancer identification where this technology could be really helpful. Now, the second kind of paradigm that we think of is what I call comparative fluorescence applications, where it's not enough to just know if it's glowing or not, but you need to know how much is it glowing, especially in comparison to other tissues within the body, or maybe within the same tissue in a different region of that. So I think the most obvious application for that is perfusion assessment of anastomoses, either before or after the anastomosis. I think that was brought up by Dr. Giulianotti and others as well. But the other one too is once cancer is identified, how much how much margin should the surgeon be taking, and providing an assessment of the cancer margin may be useful. How do you take out enough of the cancer, as much of the cancer as possible, while also preserving as much healthy tissue as possible? That's another important application of comparative fluorescence. And so if we walk through an example of a comparative application, I like to think of colon anastomosis. So here we know that leak rates are still too high. I think anywhere from 5 to 10, 15% based on the latest literature. We know it's a multifactorial problem. It's not just based on the viability of tissue, but we think there's an opportunity to drive that those leak rates down. So here's an example of a colon where the vessels have already been ligated. You can see in the center here that there's no fluorescence. So now the surgeon has to determine where to transect the colon and where is the ischemic boundary. And today, surgeons know it's somewhere in these regions here, but what is the right level of green? What is the right level of fluorescence intensity a surgeon should be looking for to call the ischemic boundary and make the transection? That is based a lot on experience and subjectivity by the surgeon. There's no defined rule as to how much green is appropriate. And the level of green, as Dr. Chen talked about, can be affected by many things, such as distance from the tissue, dosing, body habitus, administration method, timing of activation of fluorescence and firefly in relation to the injection of ICG. A lot of factors go into how green the tissue appears. And so our goal then is to enable a more objective assessment of fluorescence for the surgeon to help guide surgical decision making. So what additional information, what additional measurements can be extracted from this image to better assist in clinical decision making? We believe through the combination of firefly or fluorescence imaging technology, our stereoscopic vision, our 3D images, and the addition of artificial intelligence and machine learning, that there is a way to provide a more objective information about the tissue. And a lot of examples of this have been referenced here by our previous speakers. So quantification of the fluorescence, looking at the temporal profile of fluorescence, how ICG's uptake in the tissue, and then how it decays, how the fluorescence decays over time, and also tools that allow the surgeon to compare specific points of the tissue in terms of their fluorescence properties can all be really helpful. And these are all things that we're exploring. However, I think what we've learned, or we are learning, is that while we can extract a wealth of information from these images, The challenge is developing a user experience that is easy to understand for the surgeon within the context of surgery. We can throw up a bunch of numbers, we can put a bunch of images, but if it's not easy to understand and it doesn't fit within the surgical context, it may not actually be providing any benefit to the surgeon. So that is a challenge we're working on right now, is how to deliver that great user experience for the surgeon. Now, when I talk about this application with surgeons, oftentimes I'll hear surgeons, a colorectal surgeon say, I want the system to just tell me where to transect, where should I cut? And that may be achievable one day. We think that may be achievable, but it's going to require a tremendous amount of clinical evidence and data to get to that point. And I loved hearing the speakers talk before, because we're humbled by what the clinicians and technologists are using our technology for today. And we hope that one day we can get to that point where we can gather that data and maybe provide additional guidance by the system automatically to help determine where the clinician should cut. Now, ICG-based applications are tremendous, and ICG itself is a fantastic drug and has helped improve the outcomes and the workflow for so many surgeons and patients. But there are other future clinical applications that we think firefly and fluorescence imaging can help address. I'm going to show a few images here of some clinical applications that are under evaluation. So on top, you'll see the white light image, and on the bottom, you'll see the firefly image. The first one here is the visualization of prostate cancer. You can see in this image here, the prostate has been removed. We're looking at the wound bed. And when we turn on Firefly after the imaging agent has been injected, we see two hotspots, two areas of fluorescence that weren't readily apparent as potential leftover tumor or cancer. Similarly, if we look at lung cancer, in that white light image, it's very difficult to identify where the tumor may be. After injecting the imaging agent and turning on Firefly, it becomes much more apparent, and the surgeon can take the appropriate actions. And then perhaps more relevant for this group here is visualization of ureters. We know today that a lot of colorectal surgeons are using either lighted stents or retrograde injections of ICG into the ureter. And they work well, but they present significant workflow challenges. And so if there's an opportunity to provide a drug that acts more like ICG, but can be processed and excreted by the kidney into the ureters and injected like ICG, that may address some of those workflow challenges. And so these are all applications under evaluation that we're really excited about for Firefly. Now, Firefly is fluorescence-based imaging, but there are other interesting technologies. Everything I've shown you before are really what we call exogenous imaging techniques, where it requires injecting a dye. But there are technologies that can help visualize endogenous properties of tissue. One such example from this paper here is hyperspectral imaging. In this paper, it's been used to evaluate the skin flap here on a chin, and it's showing, as you can see in the middle image here, oxygenation saturation levels across the flap. And what's interesting here is it's not relying on a dye. This is an endogenous property of the tissue, so you don't have to worry about injecting. You don't have to worry about timing. You don't have to worry about a residual ICG in a after ligating a vessel or anything like that. So the potential benefits here are tremendous for these other types of imaging. This is certainly a newer field, but something that we're keeping track of. And then lastly, we talked about how we have this VR headset essentially on our surgeon console. That may give us the ability to better integrate fluorescence imaging with other imaging modalities. On the left-hand image here and on the middle image is a picture of our Iris service, which converts preoperative CT scans into 3D segmented virtual models that the surgeon can use for preoperative planning as well as intraoperative guidance. Currently in our pilot program, which is focused on kidneys and partial nephrectomies, what we're finding is our urologists are using iris to preoperatively plan for the surgery, and better understand the vasculature within the renal hilum. They're then using ultrasound to confirm the location of the tumor within the kidney, and then they're using firefly to confirm that they're clamping off the right vessels when they're doing the partial nephrectomy. So 3 imaging modalities are being used for one procedure. We believe that there may be an opportunity in the future to better integrate fluorescence, preoperative imaging, and ultrasound into an experience that is more easy to understand for the surgeon and easy to better fit within their workflow. So with that, I went through that kind of fast, but hopefully that gave you a glimpse into how we're thinking about the future at Intuitive for fluorescence imaging and imaging in general. Happy to answer any questions from the audience.
Thank you very much, Anoop. Really, I enjoyed your presentation. Let me ask you a question. I would like to expand a little bit the concept of integration, because as I told you, I think the future is a better anatomical understanding. And if a surgeon is able to understand well, any kind of complex procedure can become doable. Majority of injuries and complications, they happen when surgeons don't understand well the anatomy. It could be the edges of a tumor, the presence of a nerve, or the vascular pedicle. So the question: how far are we from having an integration of fusion images at the real robotic console, having say preoperative CT scan, and you think that would be doable having overlapping of preoperative images and real-time images that you can get with fluorescence or with autofluorescence or different modalities of visualization, and the integration of all this information becomes exceptionally valuable, in my opinion.
Yeah, a great question. Yeah, I agree with you that there is a tremendous opportunity here to integrate all these different visualization modes. I can say that it's certainly possible. It's certainly possible. I think it will come with some limitations, at least initially. If we're talking about, for example, integrating preoperative imaging, as I showed before, we have our iris service that allows those preoperative images to be converted into 3D virtual models. If figuring out how to register the images, making sure that they overlap correctly and accurately is certainly a challenge, but something that there's been a lot of progress made in the industry and in academia as well. I think one of the main challenges will be, once you start manipulating the tissue, how well can those 3D models actually match the tissue, and is it still providing value? That, I think, is an unknown question, and it's certainly going to be a challenge. But once we were able to overlay those images, it then becomes relatively trivial to also overlay in things like fluorescence as well. So I think, to answer your question, we believe it will be valuable. It's something that is definitely feasible at some point in the future, and it's something we're currently exploring today.
Thank you so much. And I think with this interesting presentation, opening the perspective of the very near future, and we are closing this webinar. Giving appointment to our friends and colleagues for the next webinar that will be in December 1st, and on complex hepatobiliary surgery. Thank you very much.